Good evening, and it's
Abhi,
my pleasure to be.
Dr. Badwe, abhi nahi.
Okay.
Yeah. So, everybody, on behalf of the organizing committee, I welcome you all. The faculty and delegates joining for the first time, a few words about this series of seminar and the organizers. We are a group of oncologists dedicated to the oncology in general and breast cancer in particular, with an experience of 15 years to 40 years. Since the onset of pandemic, we are regularly conducting these online seminars under the title Focused Studies in Breast Cancer. We are very proud and happy to announce that today is 25th seminar. Throughout this series, the response is very enthusiastic, and today I have been told that we have almost more than 350 registrations. Today, we have very eminent speakers, Dr. Badwe and Dr. Alexandra. Dr. Badwe will be formally introduced by my colleague before the start of his talk. After the talks, we will be having a panel discussion again by very eminent faculty from across the country. With these few words, I once again thank our faculty and delegates and hope that today's session also will be as fruitful as before. Thank you. Over to Safalta, please.
Good evening, everyone. Thank you, Dr. Rajiv. Dr. Rajendra Badwe. Every oncologist in India knows him. He's director of Tata Memorial Hospital and Padma Shri awardee, father of hundreds of landmark studies and practice-changing trials, especially in breast cancer, head and neck cancer, and cervical cancer. Let's listen to him, his perspective in the screening of breast cancer in Indian population. Over to you, sir.
Good evening, and it is my pleasure to discuss screening. That has been my hobby horse for a long time. And thank you very much for running my slides from your end. Let me just kind of open it at my place so that I know exactly how it's happening. Okay. So in general, if one speaks about screening, whether it is developing country or developed country, what is important is to understand that there is a little bit of difference between what we do in developing country for treatment of cancer versus what screening is. If a patient has a problem, she approaches a doctor and then is investigated for maybe a lump or discharge or pain in breast. And finally, she follows the treatment that is offered. What is different here, that there is a covenant between patient and the doctor, wherein patient has sought the opinion. Whereas in screening, we reach ostensibly normal individual and tell the lady that you are at risk. Please undergo this test. And then if there is something wrong, something more will have to be done. That covenant is very different. If in India, in high-risk population, when I say high risk, I'm talking about, say, 50 plus individual or maybe 40 plus individual, the risk of breast cancer is approximately 60 to 70 per 100,000 population. But when it comes to screening, I'm not talking about the 60 to 70. I'm talking about the rest of the 99,700 individuals. So huge difference in the number that we need to tackle when it comes to trying to reach these individuals. That's one difference. The second difference, when we're talking about a clinic, we talk about survival. That means I have treated 100 patients and 60 out of that or 70 out of that are living. That is survival figure. I want you to look at this example, which is there in front of you, that if I were to look at survival, the 5-year survival, if it is improved by early detection from 60 to 75%. Now, I want you to look at these two lines in the table. I'm screening 50,000 populations and there are 50,000 controls. If I were to screen these individuals for 5 consecutive years, I will have approximately 350 cancers. This 350 because of screening, because I increase the number and I pick up early as well as late. And there are late cancers detected in the control arm, depending upon what is the sensitivity of that individual to detect her own cancer. So 200 cancers detected. You will find that there are 87 deaths approximately because I'm having a 75% survival. Whereas on the control side with 60% survival, there are 80 deaths. Do you see the controversy here? That you have actually improved survival, but have increased mortality. Instead of 80 per 50,000, there are 87 deaths per 50,000. And why am I looking at 50,000? Because these are not individual ladies who have symptoms. These are 50,000 normal ladies. And I have asked them that please undergo this test and I will pick up something which will have a greater chance of cure. So you understand the difference, that the denominator for these 87, when I'm talking about survival, is 350, whereas the same denominator for mortality is 50,000, and that remains the same on either side. There are cancers that remain silent on the control side for quite some time. So once these two differences you have understood, we can now get on with the actual screening procedure. What is the data and what's the most suitable thing for us? Next slide, please. Now, let me give you some background. There are 3 modalities of screening. There is breast self-examination, there is mammography, and there is clinical breast examination or physical examination. Every country uses this interchangeably, either by a trained healthcare worker or by a nurse or by a doctor. Any of these are possible for delivering clinical breast examination or a physical examination of breast. Now, as far as breast self-examination goes, 2 large randomized trials, Chinese and Russian, both are negative. There was early detection by breast self-examination, but no reduction in mortality. And majority of the times, it is because of non-compliance to performing breast self-examination at regular intervals. Not every woman is up to it. So, a good tool for early detection, but not a good tool as a screening modality. Let's look at mammography. Mammography has shown a 30% reduction in mortality in women above 50 and no difference in women below 50. But across all ages, there is a 30% overdiagnosis. I have purposely written into bracket 55% because this 30% is essentially for invasive cancer. If I were to include DCIS, then that number will go to 55% overdiagnosis. And this is at the end of 20 years of follow-up. That means at the end of 20 years, there are 30% excess cancers in mammography arm versus control. Let's look at clinical breast examination. Mumbai trial was the largest trial and which showed a reduction in mortality without any reduction in, without any increase in overdiagnosis or excess diagnosis. There was, I will give you the details once I present that data. Next slide, please. Can I have the next slide, please? Okay, so let's go down to the data down the memory lane, 1963 to 1982. There was only one major trial that happened, and that was HIP study, which looked at physical examination plus mammography versus awareness. That showed no benefit below 50 and 30% reduction in mortality in above 50. But it was not possible to understand what contributed to this 30% reduction. Was it physical examination or was it mammography? So ideally, one should have run a trial of clinical breast examination versus nothing. One should have also run a trial of clinical breast examination versus clinical breast examination plus mammography. So how much mammography adds to clinical breast examination? And simultaneously, there are multiple trials that happen of mammography versus nil, mammography versus nothing. And that clearly showed a 50% reduction, as I had mentioned in my 30% reduction, as I had mentioned in the previous slide, in reduction in mortality, and no reduction in women below the age of 50 years. Next slide, please. Let's see what happened next. Can you go on to the next slide, please? Okay. But the problem was that there was huge amount of overdiagnosis with mammography. So no doubt, 30% reduction in deaths, but there was a huge amount of overdiagnosis. And that overdiagnosis is now clocked at about 30%. That means 30% individuals will be stamped with a stamp of cancer, but that would have never manifested in the control arm, or had the lady not had the mammography at all. Next slide, please. Other than overdiagnosis, I'll give you some data. Next slide, please. On what has happened at population level. You will find in the first graph, the population level, the red dotted line, a huge increase in UK as far as the incidence of cancer is concerned. And compared to that, the places where there wasn't any introduction of screening, it was a straight line. The second forest plot gives you an approximate numbers of 52% increase in incidence of cancer wherever screening has been introduced. So fairly large amount. Suffice to say, we need not debate on whether one is more or the other is more or something like that. But suffice to say that there is a problem as far as overdiagnosis is concerned. And that's sizable. Next slide, please. Can I have my next slide? Okay. With overdiagnosis would also come overtreatment. And that treatment-related mortality doesn't exist at the moment. Let's not talk about it. But unnecessary radiotherapy inducing cardiotoxicity as well as lung cancer, even if it is very small, that would reduce the possibility of reduction in all-cause mortality, since this is the commonest cancer in women across the globe, and India now is no exception. So overdiagnosis on screening is an important problem. Not only that, overtreatment, lot more mastectomies, lot more breast conservation. So all that put together, fairly large amount of women getting unnecessary interventions. Next slide, please. Can I have my next slide? Am I audible?
Yes, sir. Yes, sir.
Okay, yeah. No, the slides were not moving. I was wondering what happened. Okay, so let me give you the Cochrane review conclusions of the mammography screening. That overall, in women above 50, there was a 15% reduction and a 30% overdiagnosis. 15% reduction in mortality. That's the conclusion of the Cochrane overview. And it means that for every 2,000 women invited for screening for 10 years, one will avoid death. And 10 healthy women who would not have been diagnosed if they had not been screened will be treated for breast cancer unnecessarily. Furthermore, 200 women will experience important psychological distress, including anxiety and uncertainty for many years as to that there is a threat to life and what do I do with it. Next slide, please. Let's then move on to what happened if I were to add physical examination to physical examination plus mammography. Add mammography to physical examination. And this Canadian study was run entirely in women above the age of 50, where mammography was proven to be effective, but there was no evidence whether physical examination reduced death or not. Now, this trial is also asking another question. And what is that? On the physical examination side, all palpable tumors will be detected. Whereas on the other side, palpable as well as impalpable tumors will be detected and treated. So the question that this trial is asking is it necessary to treat, diagnose impalpable tumors? Because impalpable tumors will not be treated in the physical examination alone arm. Now, at 25 years of follow-up, there was no difference in mortality, but there was a 30% excess cancers in mammography arm. Imagine 30% of women, for no benefit of added mammography, were stamped with diagnosis of cancer. Unfortunately, at that time, till Mumbai study came in, physical examination versus nil never happened. The Philippines study was flopped. It flopped because of non-compliance in 75% of women. So 75% of women diagnosed by physical examination in Philippines did not take treatment. So obviously, how will the benefit be evident at all? Next slide, please. We then move on to the Mumbai study. Mumbai study was one of the largest single screening study. 151,000 odd women who had 4 rounds of physical examination performed by healthcare workers who were trained for 3 months and then introduced in the population. And about 5% of the population that had screening also were examined by a doctor, so that the consistency that the physical examination performed by the healthcare workers was actually effective and was not missing out on anything. Next slide, please. So that's the incidence. And you will find that for the first 7 to 8 years, there was a clear additional diagnosis of more cancers in screening arm. But over a period of time, by the time we went on to 10 years, the graphs came together and there was no difference as far as overdiagnosis. So a short-term additional diagnosis of early detection and those in control arm finally manifested over a period of time. Next slide, please. Now, as far as staging is concerned, there was a clear reduction, early detection in the screened arm, and this was true in below 50 as well as above 50. Statistically significant downstaging, which is an important surrogate marker that your screening is actually effective. Next slide, please. That's the overall difference. Overall, there was a 15% reduction in death that barely reached statistical significance in all population. Next slide, please. This is for all ages. We started screening at 35 and ended at 65. Women above 50, a huge 29% additional reduction in deaths related to breast cancer. And there was also a 7% reduction in all-cause mortality. So there were relatively less deaths in all causes and a significant reduction in deaths related to breast cancer, women above 50. Next slide, please. In women below 50, there was no difference. In fact, for the first few years, there was this blue line which is on top. There was an excess mortality in the screen now. I will not go into the details. Suffice to say that in spite of downstaging, there was no difference in mortality. Exactly same as what is seen in mammography versus not. Next slide, please. I mentioned to you about all-cause mortality. To conclude, that there was a significant downstaging by clinical breast examination and a significant reduction in deaths related to breast cancer in women above the age of 50. Whereas in women below 50, there was no difference at all in spite of early diagnosis. So obviously there is something more to it than what meets the eyes. That there is a downstaging that happened with mammography in women below 50, but no difference in death. There was downstaging that happened in women above 50 and 30% reduction in deaths related to breast cancer. So obviously, biologically, there is a difference in effect of downstaging below 50 and above 50. Next slide, please. I wish to acknowledge Dr. Mitra and the whole team's contribution to this Mumbai study. And I can then go on to the next slide, please. I think did you skip a slide in between or okay. So no, go ahead. Next slide, please. So the final word would be that mammography saves 30% of lives in women above the age of 50 and 28% to 52%, depending upon you call overdiagnosis of invasive cancer, then it is 28%. If it is overdiagnosis including DCIS, then 52% overdiagnosis with mammography. CBE also saves 30% of lives in the same age group without overdiagnosis. And no modality is effective in saving lives in women below the age of 50, but both mammography as well as CBE reduce or induce downstaging. That means they reduce the primary tumor size at diagnosis all across. I guess that's my last slide. Next one, please. Yeah. Thank you very much.
Thank you, sir. That was a great presentation and very clear insights about screening. So should we take the questions now only?
Yeah, I guess I'll be happy to do so.
Okay, sir. There are two questions from the audience. First one is the higher mortality in a screening population is it due to treatment? As you mentioned, sir, that
well, that higher mortality does not reach statistical significance, but there is higher mortality, and that is not easy to explain. The reason is, if you look at any of the studies that look at which decade has the best survival, I draw your attention to a paper by Adami. This is 1986, New England Journal of Medicine. That gentleman looked at 150,000 women with a 15-year, 99% follow-up and looked at what is the mortality for every decade. Every decade, the best decade was between 40 to 50. The best survival was between 40 to 50. So if you have the best survival between 40 to 50, unlike what we believe that women above 50 are actually supposed to do better, postmenopausal, we feel that they have a better prognosis, but that's not the case. So if they are already of a better prognosis, then the numbers are less, deaths are also less, and the efficacy parameter of reduction in the stage of the disease may not appear so quickly because of both those factors. So that may be statistical, but suffice to say that in spite of downstaging, there is no reduction in mortality.
okay, sir. The second question is, 1/5 of the breast cancer cases detected by mammography are DCIS. And there is an increase in DCIS diagnosis after mass screening. However, mammography has been widely used for breast cancer screening in high-income countries, and it is effective in reducing the breast cancer mortality in women older than 50 years. What about younger age? So I think you have addressed this question, but if
Yeah.
you want to say something
But
else.
let me tell you, no country in the world advises as a government prerogative or a government advice that women below 50 should be screened. No country in
Yes.
the world. That's an important thing to understand.
Hmm.
And if there is anybody who has read AJAX trial from UK, that's the trial which looked at women between 40 and 50 alone. Similar to the Canadian second trial, which looked at only women between 40 and 50 and did not show any difference. But the AJAX trial is showing a difference in mortality for women below the age of 50. That means below between 40 and 50. The difference between the two trials is that in Canadian trial, all women in the screened arm had screening and no woman in the control arm had screening. Whereas in AJAX trial, any woman who reaches 50 starts screening even in control arm. So by the time 10-year follow-up comes in, everybody in control arm is also screened. So AJAX trial does not compare screening versus not. It compares early screening versus late screening. So that's not a screening trial, but it is if the country is following screening above the age of 50, then is it worth adding one screening below 50? That's the question that they are asking. They're not asking a question of screening versus not in younger women.
Okay. Thank you, sir. So,
Thank you.
Dr. Safalta, over to you.
There is some connection issues from Dr. Alexandra's side. She's trying to connect same thing that happens in India. So now over to Dr. Arun Goyal, who is the vertebral column, the most strongest pillar of this group, and Dr. Vaishali Zambre, who is heading breast cancer unit at RGCI. Over to you, sir, and ma'am, for the panel discussion.
Yeah. Thank you, Dr. Safalta. Can we have the slides for the panelists, Priyanshi? Yeah. So Dr. Rajendra Badwe has already been introduced and Dr. Alexandra is yet to join us. So instead, then we will start panel discussion, and in case if she joins, we can have a talk at the later date. So let me introduce the previous slide, please. Yeah, so we have amongst us very wonderful panel members. So we have Dr. Seenu, who is a professor and head of the unit of general surgery at All India Institute of Medical Sciences, and he is a very dear friend of Dr. Arun Goyal, and we have had his talks and presence in many of our webinars. Welcome, Dr. Seenu. Next slide, please. I think Dr. Sarkar is yet to join us. He will join us soon. And we have Dr. Gaurav Agarwal.
I have joined.
Yeah, okay.
I have joined.
Sir, okay. So Dr. Gaurav Agarwal is a professor and head of endocrine and breast surgery at SGPGIMS Lucknow. And Dr. Diptendra Sarkar is a clinical and research lead at Comprehensive Breast Services Department of Surgery at IPGMER, Kolkata. So I would request Dr. Arun Goyal, sir, to please start the panel discussion. Over to you, sir.
Thank you, Dr. Vaishali. I think it's a webinar which I have been looking forward to for a long time. I think Dr. Vaishali and other colleagues of mine will vouch for this, that over last year or so, every time we discuss about the topic for the next webinar, I have brought up this issue. So it's screening for breast cancer definitely is a very controversial topic, particularly when it comes to developing countries. And so we expect a lot of opinions from this eminent faculty. I think we can just remove this presentation and maybe we'll first go ahead with the discussion. So first and foremost, let us say, so there are a lot of issues related to the trials which form the basis of mammographic screening. But let us come to one fundamental fact. The fact is the incidence or risk of breast cancer. So the countries which have introduced population-based screening, they have a significantly higher risk of breast cancer, where the lifetime risk is around, say, 11 to 12%. When we talk of the Indian population, the lifetime risk on an average is around 3%. I would say it may vary between different states or different ethnic groups. So it is a factor of 4. So from 12% lifetime risk to say 3% lifetime risk. And if we talk of any screening effort, the effort required in terms of intervention, so the baseline is the particular population which you want to address, but the benefit that you want to derive is based on the risk of cancer. So directly there is a factor of 4 when the potential benefit gets reduced. So I would like to know from my panelists, and maybe we would ask Dr. Gaurav Agrawal, Dr. Seenu and Dr. Sarkar first, that should a country like India even be thinking about screening for breast cancer when our population risk is say 1/4 of the high-risk countries in the West? So one by one, maybe Dr. Sarkar, Dr. Seenu and Dr. Gaurav, all three of them.
Thank you, Dr. Goel. I mean, the first and the foremost statement that I would like to make is that the government of India in 2017 has rolled out a program on breast cancer screening. The question whether India should be having one or not is not here. The question is, yes, India has already launched a program. Now, the word screening, the way it is being perceived in the West, is completely different. Here, the model is early detection, and that is based on the results of the trial that came out from Katsi Dr. Badwe from Mumbai on CBE-based trial, which was published last year in February in BMJ, but the government has rolled out before that in 2017 based on the available data that the reduction is around 15% below the age of 50 years, around 20 to 30% above the age of 50 years. And if you look at the population demography, you'll understand that 19 crore people in India, ladies, are above the age of 30 years. That would mean at an incidence of 1 in 28, the actual number should be around 6,50,000. And India presently actually records 1,71,000. So what actually you are stating is based on what is being recorded in certain small patchy cancer registry. But if you look at the overall picture, it is reporting of 1/4 of what the actual incidence is. And the CBE-based program has already been launched out, and it's a part of the National Non-Communicable Disease Program. So we should not be arguing whether it is feasible or it should be rolled out. It is already in place.
So, Dr. Sarkar, you said we are detecting only 1/4 of the cancers. So I would like to disagree. So the trial which was published from Mumbai doesn't show that the incidence of breast cancer in the intervention arm increases by so much. So there is a difference of 30% or so. So that we are not missing so many cancers if we do not do a population screening. Dr. Seenu and Dr. Gaurav, what would be your opinion?
Yeah, Arun, thank you. Thank you for inviting me to take part in this panel discussion. First of all, though Deeptendu is telling that the government has introduced some program in 2017, I'm yet to see any patient who has been screened under this program for breast cancer. That is number one. And number two is what all of us have all along been saying, whether it is Dr. Badwe or you or Dr. Rajiv, for the incidence of breast cancer which we have, even if we think that we are missing another 25% or so, our incidence is still very, very low for having a screening program. And the second important thing is that when we look at the age, mean age at which our cancers occur, these are in the 40s. So if you want a successful program, then it has to start somewhere when the patient is 30 years old. And so what sort of a program can you have for women who are 30 years old? And so that is the crux. So I do not agree with what Deeptendu has said. And my concerns are same, that like by doing a screening, which the West is doing, we are increasing the absolute number of cases. So naturally, your survival rates will become better. So unless you show me a screening procedure which does not increase the number of cases, but brings down the mortality, I think that is the screening method. And currently, there is no such screening method available which can be applied in Indian settings.
Sinu, can I be
go
the
ahead?
devil's
Dr.
advocate?
Gaurav.
Can I? Yeah.
Should I? Yeah, okay. Please. Yeah. Good evening, everyone. Good evening, Dr. Badwe, Dr. Goel. So nice to see you all around. And let's make it a little more lively. So we already have to some extent, contradictory views from Deeptendra and Sinu, both good friends. Let me first draw attention to certain facts. And this is not for this eminent panel. This is for the general audience that I'm sure is also trying to make some head and tails out of this discussion. Are we not sure that breast cancer is the commonest cancer in women in India today? Any nods of head? Okay, I see number of heads nodding. Are we not sure that roughly 50% of all breast cancer patients treated today in India, they die of this disease? Are we not sure that approximately 50% or in certain registries, 60% of all breast cancer patients even today are diagnosed in stages 3 and 4? So while the question that Dr. Arun Goel posed to all of us, is it necessary for India to embark on breast cancer screening? Well, yes, certainly. The answer is that is my answer. We may have lesser incidence compared to many Western countries, but the fact remains that we diagnose the largest number of cancer patients being diagnosed in India, they come from this site, breast cancer. And quite a few of them are diagnosed in late stages and many die. What do we need to do? What do we need to do to reduce the cancer mortality? I mean, let's forget about everything else and just stick to the most crucial outcome index in oncology, overall survival. Agreed? Can there be two opinions about downsizing, downstaging of cancer breast, resulting in better survival rates? None? So I am not bothered about diagnosing DCIS, especially low and intermediate grades, and certainly not, and I'm also even not bothered about diagnosing T1 disease. But I am right now bothered about not needing to see any T4B and metastatic and T4 disease. And in order to achieve that, we have to bring in awareness, screening, and early diagnosis. So to some extent, I agree with Deeptendra that our approach, the government of India's approach today is that of early diagnosis and not in a purist way screening, but then Dr. Badwe's trial and some other trials or many studies have shown us that clinical breast examination too is a method of screening. So I think this is my opening statement as far as need for screening is concerned. I would like to counter your argument here. So if we are talking of, say, late diagnosis and high mortalities, is it restricted to breast cancer? No. In India, if we talk of late diagnosis, it is true of each and every cancer, whether it is breast, whether it is head and neck, or any other cancer, cervical cancer, though the incidence is coming down. So the basic question is the approach. One, what is the reason for this late diagnosis? Okay, it may be lack of awareness. It may be lack of infrastructure for cancer treatment in large parts of the country. It may be lack of financial resources for the people. So there may be too many other things which, if we do not address and we only say screening as a solution, and when we talk of screening, we take it in a particular way where you have a target defined population which is identified, which is invited, which is examined, and based on recall rates, further investigations. So I have a slightly different take on that. Now, let us have from Dr. Badwe what he would like to say about this.
So in my opinion, downstaging happens with CBE as well as mammography. CBE is easy to implement in India, and it is a very rational decision that we should have it.
Yes.
It can start as an opportunistic screening, but it is also an important aspect that if it is formally introduced through Anganwadi workers, through ASHA workers, that much quicker it will happen.
Yes.
I would like to share a second component of that trial, which has gone unnoticed, and we are writing it up again. And that is the arm that had 4 interventions of physical examination at 1.5 years interval also had awareness being introduced every time they spoke. Now, 4 rounds of awareness. And when we looked at a 20-year follow-up, there was an early detection even beyond 10 years of follow-up in the screened arm. There is no screening happening there, but yet there was an early detection in that arm. So awareness also helps.
Yes.
In my opinion, we need to disseminate that. There is no question that some form of early detection is required, because if the disease is detected early, we may be able to avoid some treatments which may not be required in all. Secondly, breast conservation would be easily possible. So that's another positive side of it. And if we were to have that early detection without any harm done, that much benefit. There was also a mention of stage 4 breast cancer. I would like to draw attention of all. I had looked at the Tata Hospital data from 1974 to 84, 10 years. In Tata Hospital at that time, we had isotope bone scan, isotope liver scan, and chest X-ray as the screening modality for metastatic breast cancer. At that time, the average tumor size was 7.5 centimeters. And the incidence of metastasis at presentation, I'm talking about distant metastasis, not supraclavicular and locally advanced disease. No, it was 10%. I also have similar data from AIMS. Again, 7.5% average tumor size in those days. And they also had chest X-ray and bone scan and a skeletal survey as the modality, and liver scan. And the incidence of metastasis was 11%. I looked at data at Thames Cancer Registry when I went to UK. And Thames Cancer Registry had, at that time, between 1982 to 1987, that's the data I looked at, the average tumor size was 2.6 centimeters in those days in UK. And in Thames Cancer Registry, the incidence of metastasis at presentation was 10%. Today, SEER reports an average tumor size of 1.5 centimeters in US. The incidence of metastatic disease at presentation is 9.5%.
Yes.
So there is a huge amount of early detection. The numbers of early detected have increased enormously, and transition from stage 3 to stage 2 and stage 3 to stage 1 is there with every detection, but stage 4 does not change. There is something else that
Yes.
determines metastasis at presentation. Thank you.
Yeah. So basically about we were looking at delay in breast cancer. So when I was in IRCH James, then also we did a study at that time in IRCH, the mean delay was 11 months. And about 2 years back, I did a study at Max Vaishali only, and where Dr. Vaishali was also a part of it. And the average delay was around 6 to 7 months. That is from the first symptom to the time that the patient came to us. So
Right.
I think one that delay which is happening even when the patient is becoming aware is a very important contributor to late treatment and mortality. So there are many elements which we need to work on. And I would like to ask one thing of Dr. Badwe in the Mumbai trial, like the treatment of all the patients who were diagnosed was at Tata Hospital, or how was the sort of patient treatment being handled?
So 90% of the treatment for screened arm happened at Tata Hospital.
Okay.
And 80% of the treatment in control arm also happened at Tata Hospital.
Okay.
But we looked at the standards of care on either side, and there is no difference in the kind of treatment that was taken on either side.
Yeah. But probably when we talk of the whole country and we think of a program, see, a limited rollout in a small geography is one thing, and rolling out such a program in the whole country, and then we need to have a tie-up for recall rates, investigational workup, and treatment support. And I think there are huge gaps there. So probably that is an area which needs to be addressed there. So Dr. Sarkar, that the rollout which had happened in 2017, how much of the country is covered? What part of the population, which states?
Yeah, wonderful question. Actually, I rolled out a 4-layered pilot screening project in West Bengal in 5 districts, taking into consideration the data, the completed published data of Dr. Badwe, as well as the due publication from IARC. IARC Trivandrum data is almost showing the same results. So there are 2 robust RCTs which states that it is beneficial. It reduces the population mortality rate. 1. Number 2, if you reopen the file of the Swedish 2-county trial, you would understand that that was a trial which had a huge confounding bias. I mean, one group, which was the intervention arm, was given everything. The other group was the stepson. They were not even taught about breast cancer. So what extrapolated out of that in 1980s is absolutely nonsense. If you reopen the trial, you will find there were fallacies of the trial. Now, coming to what the government rolled out in 2017, and I thought the things are not in proper affairs. And when I went to the Department of Health in my state, I told what is happening to the trial. I mean, what is happening to the program. Now, I have 2 criticisms against the program. Leaving aside the criticisms, the official who was sitting there in a fraction of a second showed me the data of CBE that was done in the Sushasto Kendro, that is wellness clinic. Now, what the government of India has done in this program, they have targeted 3 cancers: breast, oral, cervix, diabetes mellitus, hypertension, and mental health. And they have provided all the CHOs who are working in the Sushasto Kendros with a mandatory tab. And every day, whatever CB is being done, it is uploaded. And that data is open to all the state government, to the central government, as well as to the IARC in Lyon, France. What is the problem with the program is, now suppose I am not naming a state, a particular state had 20 lakh CB being done in a span of 6 months. Now, what came out from the data was that the number of referral was only 20. Now, what IARC states is that you are supposed to have a 6 to 8% referral if you do a CBE. So if there is only 20 referral, that means CBE was not done appropriately. So therefore, on 4th February, if you go to the WHO website, you will find that IARC have launched a CBE training program. And what we have started in the state, I did a webinar today morning with all those CHOs, not the ASHA workers. The ASHA workers and the Anganwadis would be trained in BSc, whereas the CHOs, the community health workers working in the Sushastha Kendras or the wellness clinic are trained in CBE. Now we have classified 7 zones. They have to take those 7 zones. If it is done appropriately, if it is put under a good surveillance, I can promise you what Dr. Badwe's data has shown is going to do a magic for this country. There are 2 areas where this program can be criticized. Number 1, I have already written to ICMR that it is being run at an interval of 5 years, which I thought was atrocious. The data is from 2 years. In 2017, Dr. Anurag was there, Srinu was not there in the meeting in Delhi. We always told that make it 3 years, but later on when the government came out, they told it's 5 years. So now that the data is available, we must rewrite that the interval should be 2 years. And if you do that, I'm sure we are going to see a huge downsizing and a reduction in population mortality in next decade.
Okay. So, Dr. Gaurav, there is a Trivandrum trial, the publication, full text publication has come out recently. And the benefit which has been documented is not as much as has been reported in the Mumbai trial. So what would be your take on the results and comparing the 2 trials?
Yes. My perception is, as far as this question is concerned, comparing the Mumbai trial versus Trivandrum CBE trials, Kerala has a much better health awareness levels as a baseline. Yeah. Much of the success of this trial or these trials is on account of creating better awareness. Okay. And as has been shown, even in Mumbai trial, even the control arm had so much better diagnosis rates. And even after completion of the intervention, early diagnosis continues. So my presumption, without a head-on comparison, doing a head-on comparison, is that because we had a already well-aware population in Kerala, in Trivandrum, they did not achieve that kind of downstaging and that kind of better cancer outcomes. Though they did say downstaging has also been reported by even the Trivandrum trial. But can I take 1 minute to comment on the current Government of India program? Professor Badwe led that team. I remember in 2014, I was part of that team which prepared the ICMR clinical practice guidelines, the original documents. We proposed once every 2 years clinical breast examination and VIA for cervical cancer. And the same document was then rolled out, was published in 2015 without much change. But when it was rolled out, the difference made was once every 5 years. And that is entirely because of logistic reasons. That is all history. But what I want to tell you is what is happening on the ground. The uptake or participation in the program is dismal, as you can expect. As part of our state's think tank, I've been participating in various such discussions. Our CHOs also fill in this CBAC forms on their tablets. They're also supposed to do a certain number of CBEs and VIAs, not VIAs, sorry, for VIAs, they have to bring the clients to the PSCs and then onto sub-district centers. But all this data is being captured, but very few positive CBEs and hardly any referrals for treatment. But when we are doing a concentrated or focused program in certain blocks, there we are finding much better uptake, much better detection rates. Of course, no more than, I mean, I can give you data of one particular sub-block where in Malihabad, where our breast cancer initiative found two cancers, two invasive cancers in about 10,000 women screened. Another, something like 50 odd women referred for further evaluation. So it's not a big number, but all this experience, what it tells me is that awareness is an excellent tool for early diagnosis. Any amount of activity in awareness, this includes mass awareness campaigns of promoting breast self-examination and implementing even fractionated, even bits and pieces implementation of clinical breast examination by public health workers brings in awareness. A number of households which are visited by these CHOs, women do not agree to be examined. Nonetheless, they do get aware. They are passed on this message of awareness. They're shown the awareness material on the tabs. And mind you, women, they do find it attractive to be shown something on their tablets. So I feel, if not anything else, all this effort is creating a better awareness in the masses, and we are seeing the results. I mean, we have been tracking the proportion of early versus locally advanced versus metastatic. And while what Dr. Badwe said is absolutely true, the proportion of de novo metastatic is not changing much. But there's been, in our own hospital-based registry data, a reversal of stage 1 and 2 versus stage 3. In 1999 to 2001, it used to be 66-33, sorry, 33-66. Now it's close to 40-60. So 60-40, 60% stage 1 and 2 and 40% stage 3. So that kind of change is occurring. It's not because of one person's or one group of people's effort. A whole lot of effort is going into it, but the key point is awareness.
Yeah.
If I may add something, that the difference between what Kerala has found, the differences are almost in the same direction. There is no question that there is also a benefit which is smaller. And the reason is, in our study, out of the 151,000 individuals, 35% were women above the age of 50. Whereas in Kerala study, only 21% were above the age of 50. So the major difference which happens in women above the age of 50, that is being smaller. That's why the overall difference is smaller. But as we speak, Dr. Shankar Narayan as well as Dr. Ramdas, who is looking after the data there, have agreed that we will sit together and meta-analyze raw data of both the studies, so that we have a robust evidence of almost 200,000 women below the age of 50, and we will have a good data related to that, and somewhere close to about 55,000 women who are above the age of 50. So that will also be a sizable number for us to clearly say what is happening in Indian data. So maybe another 6-8 months time, we should have some meta-analysis of both the trials done effectively.
So we have, hello, So the impression that which is being generated by all this discussion is that while the clinical breast examination as it is being rolled out as a Government of India program, the benefit may not be directly related to the screening part of it, but more because of, say, awareness. So, but over a period of time, I believe there is going to be, as we improve maybe training of the manpower involved, the logistics and all things should improve. Now let us come to this issue of this age and the benefit related to age. So I think broadly we can say one is that somewhere there is a transition in breast cancer which happens around menopause, and the disease before menopause behaves differently and disease after menopause behaves differently. So the question is, why do the younger women don't have no benefit? So basic question is, is that there is a failure of earlier detection, or is the biology that even if we detect it slightly early, we are not able to intervene to improve the outcome?
So there is undoubtedly early detection, documentary evidence that there is early detection by whatever methodology you use. Mammography undoubtedly produces early detection. So does physical examination below 50. But that does not reduce mortality. What does that mean? Why do we say that there should be early detection and it will save lives? The conclusion is, even if you allow tumor to grow from 2 to 3 centimeters, there isn't much of difference in women below the age of 50. And there is probably a biological reason for it, that something is different in a woman who is below the age of 50 compared to women above the age of 50. And we need to look at, I remember discussing this with a biologist in UK, and the gentleman had this conclusion that we will somewhere down the line find the answer. Why is it happening? But in any species, women in reproductive age have a better chance of survival than women outside the reproductive age. And men have no such differences. There is a very elegant paper of impact of menarche in Sweden in mortality related to solid tumors and leukemia, and a remarkable reduction in deaths the moment menarche sets in solid tumor mortality in women, not in men, but no difference whether men or women in leukemia, lymphoma. So obviously for solid tumor, there is something different in younger women.
Dr. Sino.
Yeah.
Recently, you would also be aware that thermography is something which has actually been approved in some way for use as a modality for early detection of breast cancer. It is being marketed in some way, often direct to the public also. So would you have any sort of, what is your perception of thermography, and what do you think should happen?
Arun, you very well remember that even when we were residents, there were some studies or pictures of thermograph being used for detection of breast cancer based on the changes in the temperature which occur because of the increased vascularity. And as you said, that it is being propagated by the company which makes these machines. But I personally have not much experience with it. So when coming to the screening itself, like I have my own reservations, even whether mammography should be done in India. And also I feel that what we are talking about is that the breast cancer awareness is extremely important, that nobody denies. But as far as the clinical breast examination goes, the way Deeptendu said, very impressive, 20 lakh people, but only about 5 lakh people, only 20 referrals. So that means that something is missing there. There is no quality assurance at all in what we are doing. So unless we sort out our basics and then try to implement even this clinical breast examination, maybe it will have some benefit. But doing this patchy examination in 5 districts, 1 district, this is not true screening actually. What you are doing is everybody has a focused area of interest. You are working in it. Dr. Badwe has worked in Mumbai. Shankar Narayanan is working in and around Trivandrum. That's excellent. There's no doubt about it. But if you want to implement it as a national program, then you need to plan it differently. The way it is done currently, whether by it is government of India or by the state governments, it leaves much to be desired.
So can we ask Dr. Alexandra what is her opinion about thermography, or maybe for that matter, automated ultrasound?
Yeah, Dr. Alexandra, can we?
Hello.
Hello.
Thank you for allowing me to join you.
Welcome.
So,
I'm Dr. Arun Goyal. First of all, thank you for joining. So a lot of the discussion we had was focusing on India, but maybe we can ask 1 or 2 questions about, say, there is a debate about introducing population-based screening in younger women, say 40 to 50. So do you agree? Because the question is that, Dr. Badwe also said, that the benefit in younger women in the Indian trials has been limited. The majority of benefit is in the women above the age of 50. So what is your take on that?
So I think, so first of all, thank you very much for accepting me. Second, I must say that my awareness of what is uptake of the screening in the Indian population is probably significantly poorer than yours. So I think that we should see screening as an opportunity as diagnosing patients sooner, but it's also always a balance between capacity of diagnosis with capacity of delivering the right treatment. So if we think about targeting the treatment to the highest risk population, then the resources should be concentrated on the peak age peaks, so 50 to 70 as is for us. So if you notice that there is an extension of the caseload beyond the window that you are currently practicing, and there is capacity in diagnosing, but also in treatment, then there is purpose to expand those boundaries. But otherwise, to discuss outside the capacity of the health system to deliver the service that we are committed to is probably more of an academic value. So it may be very well and nice to screen everyone 20 onwards with any means, but then do we have the capacity to deliver the service? Do we have the capacity to deliver the treatment? And then the last question would have a significant impact on quality of life, survival. And this comes from questions like, more we scan, more we find out. But equally, more we scan, we do have an impact on the perception on the quality of life of those women. So over scanning may also have a negative impact on the quality of life. So it's very much to know what population you are helping and how you can deliver the best services to your population.
Dr. Vaishali, I'm sorry I've been hogging the whole discussion, but maybe you would like to add some questions or queries to any of our panelists.
Yes, in fact, I was eager to ask about the concept of opportunistic screening in India, especially because we have been always, we've been always taught that opportunistic screening is the way to go about in India. So I would like to ask Dr. Sarkar, Dr. Gaurav, Dr. Sinu, what is their take on opportunistic screening, and how do you guide your patients, or maybe the women who are eligible for screening when they come across such people, ladies? So Dr. Gaurav, please.
Yeah, any opportunity for opportunistic screening, in my view, should not go a begging. So if there is an aware lady willing to be screened, she needs to be evaluated for need for screening as a first step. You yourself said whether she belongs to that age group, whether she belongs to a higher than usual risk group, and accordingly, then you can make a decision or provide a suggestion for appropriate screening methodology for that particular individual. So I feel and I do get number of such women. Majority are either they are scared because a friend or a relative has had a breast cancer, especially someone with a bad outcome, or else they are simply they've been exposed to some awareness message somewhere and they want to be screened. And this is exactly what I try to do. First, go through their family history and their past histories, and then following a clinical breast examination. Now, if the lady is there, I feel the screening can be provided straight away in form of a clinical breast examination in women beyond 30 years age, for sure. I do take, I do also believe that any amount of screening and awareness messaging to younger than that age group is neither necessary and perhaps also fraught with the possibility of scaring a young girl unnecessarily. So wherever I'm counseling a family, I do make it a point to ensure that younger than 25, 30 years age even though there may be a family history, we do not alarm them unnecessarily. So, but the bottom line is that opportunistic screening is indeed very welcome.
So, Dr. Sarkar, I would like to ask if you come across as any such lady, and if you perform a clinical breast examination, say if that lady is around 40, 45 years of age, and the clinical examination does not reveal any suspicious finding. So would you recommend a mammogram for her, or would you just maybe make her aware and just leave her like that? Sir, please unmute yourself.
Now, if she presents on her own to a clinic, and believe me, again, we have done a study on what is the impact of education and socioeconomic status in terms of ignorance, okay? And we actually found, and we had presented this in the American Society meeting last year, we have been able to find that it is not part of the curriculum neither of a tribal lady nor that of a lady residing in a skyrise. Okay, so any deviation from normalcy, even in a tribal lady, appears abnormal. It is not a question of ignorance. They exactly do not know what is a painless lump, what is nipple retraction, but any deviation from normal, they would go to a healthcare system. The problem lies in diagnostic delay. The first part is pre-diagnostic delay. That's the culture, ignorance, whatever you call. The main problem lies in diagnostic delay. Now, if a lady walks into my hospital, which is a tertiary hospital, the premier institute in Eastern India, that's not an issue. The issue is if that lady walks into a small clinic in a district hospital. We have to ensure, the government has to ensure that apart from ultrasound, a cytology / a core biopsy is being done. And when we had a reality check, we understood that there is dearth of a mammotome machine or a technician who would slice the paraffin block and put it into a slide. In this regard, I am looking forward to a wonderful trial which is being done by WHO IACT in Ravi Kannan Center in Qatar, which is looking at FNAC from which ER/PR HER2 can be studied. Because again, if we shout that we need to take core biopsy to a village, it is not feasible, it is not cost effective. So we need to find out our solution to reduce the diagnostic delay. And for diagnostic delay, one of the major reasons of delay is missing out on opportunistic screening. A lady has walked in and you did not do a triple test. That in today's era would be stamped as a sort of criminal offense. For that, we need to go to the community physicians across all disciplines, modern / non-modern medicine people, and train them about the significance of triple assessment whenever a lady walks into your clinic.
Yeah, I think that's very important. Yes, sir, please go ahead.
Let me ask Dr. Seenu, suppose a lady 50 years, you do opportunistic screening, clinical examination, mammography, both are normal. Now the patient says what should be her future course of action. So Dr. Seenu, what would you like to advise? Would you say that you should have a regular mammography, or what would be your advice to such an individual? Normal population-based risk, not a strong family history.
Yeah, Arun and Vaishali, first of all, I think opportunistic screening is an excellent idea, and I follow it very, very routinely in my day-to-day practice. And as for what Arun is saying, that what will I do? Like, this is very, very common. Like, if patient has breast cancer, our attendant comes, she says, can you examine me? I think all of us face this. So I advise a woman the same thing as you have said. I first do a clinical examination. It's extremely important to do a clinical examination first, because about 10 to 15% of the cancers may not be mammographically detectable, but can be detected by clinical exam. That should be your number one after history. And second is, as I said, I get ultrasound done in women less than 40 and more than 40 mammogram. And if a woman is above 50 years, I do advise her that you do get every 2 years or every annual mammogram done. Not many patients follow it, but some patients do follow the advice. So I always take the opportunity and do screening for breast cancer as far as possible. Even in patients who present with cholelithiasis and all, I always try to tell them about awareness about the breast cancer.
Yeah, thank you. I think now we should be all eager to listen to Dr. Alexandra, because she is supposed to talk to us about the high-risk screening, which we have not discussed so far. So, Dr. Alexandra, if you don't mind, can we listen to your talk now?
Of course, I think that the slides are with the organizers, and I'll try to talk.
Yes. So, yeah, Dr. Priyanshi, can you share her slides?
Okay. If I may add two of my thoughts on the retrospective discussions. Thermography should not be a substitute for mammogram. And then clinical breast examination has never proven the value as a screening tool. Yes, it would be picking up symptomatic lumps earlier, breast awareness. We should perform it if not for the clinical purpose, which is obvious there, but also for the medical value, medical legal value, but imaging adequate to the group of age of the patient and tailored to the risk of the patient, not only genetic risk, but also social risk factors, personal risk factors, should contribute into a decision-making for for adequate scanning. I'm sure that you all have the same views, and we would all triple assess a patient if we do have the opportunity. So, okay, now probably my talk is a little bit more general than planned initially, and that is more genetics in breast cancer practice. Also, what would be the impact? How do we do it? How do we do it in this area? Area meaning UK, which is the practice of my recent years. If we can move on to the next slide, please. Next slide, please. Who would be moving the next slides? Thank you. So I'm happy for you to address me as Alexandra. I'm very much informal. I'm a doctor. I graduated in Romania, Bucharest, which is the capital city of Romania. Romania being in Eastern Europe in 2003. Following that, I completed my general surgery training, being a general surgeon certified back home in 2010. Following which, I came to UK, entering the breast surgical registry on the specialist registry as a consultant general surgeon in 2012. And then life took me from abdominal surgery, bowel surgery to breast surgery, where I've done a specialty doctor post, following by a post-CCT oncoplastic fellowship in Oxford University Hospitals, which covered about 4 or 5 years of my practice. And I had the chance to be offered a consultant job as oncoplastic breast surgeon in 2017, after a very short period of locum consultant. And that brought me to the honor to meet Dr. Razdan, with whom I worked for a couple of years, and to whom I also owe this presentation. So if we move to the next slide, then I sort of try to explain why would I be interested in any genetic assessment as a breast surgeon. Because the moment we see somebody in a triple assessment clinic, whether we are a breast surgeon or a breast physician, we have to think this is the person we have in front, but that person has a history, and what would be the most tremendous burden that that patient can come with other than the clinical assessment, clinical symptoms. So it's part of the consolidation of the risk factor, family risk factors being probably those who are easier to be identified in our society, or easier to address in some respect, and also to document, because it is important that we do find something, we'll file it, and we may come back on it a number of years later. If not for the benefit of that particular patient, the next generation may also have an interest and a benefit from the information that we retrieved from our index patient. So it's very important to document or to save the information. And last, this documentation, if it's not for the benefit of patients, also for learning purposes. And we all know this, that we keep on learning. Now, if you move on to the next page, next slide, please. So my presentation as a general surgeon would be very much see it, you have a high risk patient, think of surgery. So my approach has been significantly amended by the contribution of my colleagues from the clinical genetics, and here are the two clinical genetics from St. George's unit, who delivers services for half of our trust. The other half is delivered by Oxford by Dr. Lisa Walker. So they contributed substantively to the current presentation. So if you go back to the next one, please. All right, now when we see patients in a high-risk clinic, genetic clinic, they may be coming from the symptomatic or from the asymptomatic patient. And we are not talking about the cancer patient. So genetics here has patients who have a family history and never had a breast trouble, but they are worried about the family history. And this is the asymptomatic patient, non-cancer, but does have a family history. And those would be assessed provided they fill in the criteria that we have here on what we call routine pathway, which may take a number of months to get back. But you have to bear in mind that all these patients would have the opportunity to be clinically assessed in a triple assessment clinic if they do have any symptomatic or clinical findings on the assessment or in the primary care. And the others who are also benefiting from the routine pathway would be the symptomatic patient, but again, with no cancer diagnosis. So symptomatic or asymptomatic would not increase our level of concern in terms of a genetic burden. It's the family history who will tailor the pathway sooner or later. How do you want to assess this patient? Now, if you're thinking about the cancer patient, that is a bit different. In the cancer patient, we want to have an answer of their genetic assessment sooner, ideally prior to an adjuvant radiotherapy, which may restrict the options of reconstruction, for example. But we do know that once a patient has developed a breast cancer, the risk for the future in terms of recurrence and survival benefit is just tailored to the cancer they already have been diagnosed with. And the genetic burdens, the social risk factors are falling down in terms of priority. So we do concentrate at all costs to timely treat that patient, even though sometimes we may be so efficient that we have the genetic assessment a bit late, so following the radiation, and then we have to think outside the box on how we would do the risk reducing protocol and how we may consider the reconstruction options. And we do have what we call a direct genetic testing. The direct genetic testing is basically a way of saying that the geneticists are happy for us as clinicians to request the blood test for assessing BRCA1, BRCA2, rather than being a specialist-driven assessment. Just to be aware, genetic testing, it is in the hands of the clinical genetics with this exception. So if you move on to the next slide, please. So we do need to have a justification of this genetic assessment, and that is family history. Without the family history questionnaire that is filled in and without the consenting patient, even if we pick up on the high-risk family history, if the patient denies the assessment, we cannot go against it. And it may be even more complicated. The patient wants to have a genetic assessment, but the information should not be communicated to the family, for example. in the end, is the test of the patient. The results are relevant to the patient, and we have to be bound by the request of that patient, of that index patient. Now, whom do we test? We try to find in that high-risk family, an index patient, the one that was affected by the cancer. And the way we think is that we test the patient, we test the index patient, rather than testing everyone in the family. And if we did pick up on a mutation on that patient who is affected by breast or ovarian cancer even, then that mutation would be checked in the family tree, so in the remaining family. So if the patient is consenting, family of the patient could be tested against that particular mutation. So we don't do again the whole panel. So you'll consistently see that we are trying to manage the risk assessment, but also being mindful of the costs which are falling back onto the NHS. So if you can, and then we have to communicate the outcome. We have to be very careful on how we communicate the letters, where do they get, and when we deliver the information to ask the patient if he's comfortable with any of the family being present at the time of the discussion. And from experience, many patients attend those clinics as alone, rather than having a friend or a relative. All right, if we move on to the next one. Now, we found something. We found that the patient has a mutation, has a genetic risk that has been proven. And then we have to discuss the risk-reducing strategies. Now, of course, it is clinician-led, the indication that we do. We also pass it through the MDT because we can have that tunnel vision. There is a BRCA mutation. Oh, I need to take both breasts off, or I need to recommend a bilateral salpingo oophorectomy. But there may be more to it, and there may be that we should discuss with the colleagues and see different approaches. So it's always documented in the MDT, in the cancer database. And once that management of the patient is agreed in the MDT, then we make the recommendation, or we disclose the recommendation to the patient. And that may be, as you very well know, monitoring chemoprophylaxis, surgical reducing risk, and why not bilateral salpingo oophorectomy, because we know that this may reduce by half the risk of breast cancer. Now, all this in the context of a surgical approach. And we have something that is called GERT. And GERT is just, we try to get it right first time. So we try not to put patients through multiple surgical events or I'm not saying surgical operation, I'm saying surgical events. So on one side, we want to treat the cancer, and if possible, to do the risk-reducing surgery, the contralateral mastectomy, for example, in the same time, so we don't bring the patient back to a new hospital admission that has all these extra costs for the patient in terms of time, in terms of recovery, in terms of presentation, in terms of missing work, but also for the health system, versus the potential delay in the oncological treatment. So it's very difficult sometimes to navigate this fine line between let's do it in one go versus actually, if I put a mastectomy wound on the other side, which may have a wound complication, this may impact the delivery of the oncological treatment with adverse oncological outcome. And we have this in mind, but then we have to manage the patient's expectations. So they want both breasts off because they have this mutation that frightens them, that they have this cancer that they have treated for months, and their quality of life has been impacted by the cancer treatment rather than the cancer itself. But we have to explain that every decision that we make, it's actually in the interest of the patients. We are mindful of the delivery of the cancer, of the adjuvant treatment, which may be delayed from a contralateral wound infection, for example. But also, we are facing now the COVID exit and pressures on beds, and then availability of services. So probably it's better to do it in one go, provided we don't compromise on the oncological outcome, meaning the risk-reducing treatment, surgical treatment at the same time with oncological treatment. And we have to be mindful of the support structures of the family. We have mixed communities, and we have patients who have not disclosed to the family that they are affected by breast cancer, and some refuse certain treatments because those would make it obvious to the family that they have been diagnosed with breast cancer, and is perceived as a stigma. So we have to be a bit aware of the social and cultural environment of our patients. And the breast care nurses have an excellent input in learning and knowing about the family, about not only the individual, but the social context and the cultural context of our patients. We do have, or we try to have, as consistent as we can, a psychologist support, or a psychotherapist. And that is because some patients are so stressed about going again through another cancer treatment and diagnosis that they want both breasts off. And they don't realize that actually the risk is only reduced, is not risk canceling a bilateral mastectomy, especially when there is no proven genetic burden. So if we do need to treat one side, often they ask to have contralateral mastectomy because they think it's going to be safer. And that's not necessarily true, because as we said at the beginning, the prognosis is dictated by the cancer they already developed, which may be developing into metastatic disease. So a new cancer on the contralateral side have a marginal input in their progress. If we go on to the next one. I know that you are very much aware of all the statistics. I have followed the previous discussions, and this is what we say to the patient when they say, well, actually, I have this breast cancer. How likely is for my daughter or for my family to be affected by it as well? I must admit, even though I haven't been a surgeon for dozens and dozens of years, even in my, well, let's say 15 years that I'm doing this job, I've seen a shift, of course, shifting between countries as well. It's not perceived as a catching disease, it's perceived as a risk from the family. So really the work that we all do as clinicians in educating our population and GPs especially, and the nurses, is tremendous. So it's not like, oh, I have the cancer, will my family catch it? It's, I have a cancer, is anyone in my family at risk, or can I pass it on? So it's definitely everything that we do in educating our population in terms of attending screening, in terms of breast awareness, in terms of discussing these very soft touches of genetic risk is very, very important. If we can go on to the next slide, please. Now here we have what we call the National Genetic Test Directory, and that will give us guidance on what can we test and when can we test, whom do we have to risk assess. Even to give a family history questionnaire, we have to have a good reason. So we don't dispense assessment of the family history on everyone. Also bearing in mind that this may cause more anxiety than necessary. So we have to have a clinical indication for risk assessing. There were some changes, like breast cancer diagnosis under 40, grade 2, grade 3. We don't necessarily refer everyone to genetics with a grade 1 cancer, even under 40, unless there is some genetic history there. We test a little bit more. So what we do in practice, we are learning, and we are learning through case reports, through new genetic mutations that are found and proven to be of value or to be of risk, put it this way. If you go on to the next slide, please. So can you go on to the next slide, please? Thank you. So this is very roughly how we work. It's very simple. It's a bit of a busy slide. I apologize for that. But it's just that it's very little story behind it. So we simply ask patients, do you have anyone with breast cancer under? Do you have a particular age? Do you have how many of? And really the discussion in the clinic is rather short around genetics. Patients are very tempted to tell us about all the aunts and relatives with AYZ cancer, and we try to be very focused. because we need to educate our patients. 1 in 2 people will be diagnosed with a cancer, but not all are linked to the same genetic mutation. And what I learned is I start by asking the patients, do you have anyone on father's side or mother's side? Because I tend to receive reports only from mother's side, thinking that is gender linked. And do you have anyone with ovarian cancer or breast cancer? Because they will have that tunnel vision. Oh, I have my grandmother on mother's side had breast cancer in 90, but they forget about the grandmother on father's side who developed an ovarian cancer at 38, which may be more of significance. So we have all this list, we try to channel it. So if you go into the next one. So then what do we do with this information that we get? We have the family history. It is a risk stratification based on CAN risk, which will also take into account lifestyle and hormonal risk factors. So it's not only genetics seen in isolation, because there may be a genetic mutation of marginal impact, but if we do have the environment, then that can be relevant, and eventually that patient can be at a high risk to develop a breast cancer. So genetic risk cannot be seen in isolation. And CAN risk is inputting the data into the body CIV6 model and takes into account breast and ovarian cancer. And I'm sure you're aware, I'm amazed by how well informed my colleagues are consistently, and yeah, it's based on a population of 5,000 plus families assessed, risk assessed. Okay, so we have all this assessment and what we are looking for. Can we move on to the next slide, please? All right, so we want to find, when we do the family histories and we send them to genetics and then they are tested, what do we look for? So we do look for genes who are mutated, and we know for sure that that particular mutation in that particular gene would would be associated with a risk for developing breast or ovarian cancer, and has a Mendelian disease such as BRCA1 or BRCA2 is quite typical, right? And then we want to see, are there any other genetic mutations which may be a little bit more rare, may not have such a high risk, but in association with environmental factors may contribute too. And the last would be, as we go to the right of the first table, would be the common variants, which are, we find them frequently. We find them frequently, so most of us, no one has a perfect DNA with no flaws, let's put it this way, but again, there may be multiple mutations, small changes in the DNA may result in developing a condition. So there are many, many common variants, the so-called idea of polygenic cause of the breast cancer. If you go on to the next one. Now, this is just another tabulated way of seeing the previous slide, and it will tell us genes with high penetrance, low risk allele, and low old. So it's just the same table that we had previously, that some of us may find it easier to understand. And then at the end, on the right-hand side of the slide, we find similar the same percentages. So 50 to 20% of the patients may inherit the BRCA1, BRCA2, so you may find it in the population and so on. So lower risk penetration with lower risk for developing the breast cancer, high risk penetration, high risk to develop breast cancer, or you may have multiple low penetration genes who will have the cumulative effect. So really, in another way, express what we found, what I tried to explain on the previous slide. We move on to the next one, please. Okay. And then how do we assess those patients who are at high risk? And we have the NICE guideline will tell us roughly what should we do in general population, moderate risk population, and in the high risk population. And that table shows you only what we consider as general population risk. So just being a woman, it's already a risk to develop a breast cancer, but then being a woman and having some family history may give us a moderate risk and high risk. And the frequency of the screening, the intensity of the screening and the type of screening is age adjusted and risk adjusted. Okay, so if we move on to the next one, please. That's just to say that this is how we start learning about BRCA1 and BRCA2, and yeah, it's just an English Journal of Medicine publication that I'm sure you are very much aware of, and that's how we start to learn about mutation and what happens in those mutations that is eventually causing a breast cancer. So that's where we learned. Can we move next? Now, the polygenic risk is what we kept on saying about small mutations that may altogether contribute to that particular population or patient to develop a breast cancer, but also will be affected by the environmental factors or social risk factors of that patient. And for us, there are no current NHS tests available. And the family history that we started with, it's actually a proxy of determining those risks. So probably the moderate risk family history is those patients on whom we haven't proven a genetic mutation, but we do have a significant family history. So we don't really know where it's coming from. There may be such small mutations here and there that would contribute to the end risk. If we go on to the next one. Now, we talk about risk in women. What about men? Of course, it's not frequent, but when it happens, it's equally devastating. And it's equally devastating for the patient as well as for the family. And that is not only because in our practice, if we find probably 9-12% of women to have no positive diagnosis, we end up with up to 50% no positive disease diagnosis in men. And then you wonder what is gone wrong there. Is it the biology? Is it the person being a man with a high risk? Is it the awareness? Or is it the genetics? And really, if we talk about BRCA1, it doesn't seem to be of a significant impact. If we talk about BRCA2, yeah, there would be a risk of prostate cancer, probably higher than the risk of breast cancer. And the age of diagnosis is relatively early. So for us, all men diagnosed with a breast cancer would be offered genetic testing straight away. And if we talk about relative them, if we do not have the index patient to be tested, and we have a patient presenting to a clinic having had a parent, a father with a breast cancer, the singular family event of a male breast cancer is an indication for a genetic assessment. So if we go further, now we talked about testing the patients, and then we talk about testing the tumors. Can we learn something from the tumors that would tell us about the patients? And rather than testing the patient, can we test the tumor to see what's gone wrong with the tumor, and that may be relevance of the patient? Or knowing about the mutations that are present in the tumor, would this change the management? And I'm not talking about the surgery. It's also about the adjuvant treatment. And I think that most of you attending are from oncology, so probably are significantly more aware of the changes in the chemotherapy treatment that you may offer in the context of BRCA1, BRCA2 proven germ mutation carriers and PARPs inhibitors. Now, most of our patients, at least in our practice, are aware of the Angelina Jolie story and the BRCA. So they ask us, oh, can I have the BRCA? I have the triple negative, can I have the BRCA? And then we have to make them aware that actually it may be present in 7% of unselected breast cancer. It may be in 11 to 15% unselected breast cancer with a triple negative, or even higher to find breast cancer, BRCA1 or BRCA2 genetic mutation if there is a breast cancer and a strong family history. So probably the BRCA1, BRCA2 does cover most of the genetic mutation in breast cancer population, but it's not only that. So 50% is not 100%. So we have always need to look further if not proven. So yeah, there is also that concept of cancers that are BRCA-like. So there is no proven BRCA1, BRCA2 mutation that you know about, but there will be defects harbored on the same pathway, and therefore this cancer, which will be a wild type, will still respond to the same chemotherapy as the BRCA1 induced cancers. Again, this is important equally to the surgeon as is to the oncologist. So if we go back to the, if I may take you back to the initial idea that let's have the genetic assessment prior to adjuvant treatment, yes, that is the reason why, because may have an impact on what the oncologist may recommend to the patient. Go on to the next one. Yeah, talk about this one. Next one, please. Okay, just not to be confused with, I'm sure, about the tumor profiling, the gene expression profiling test, which will give us the recurrence scores. It's not about the same thing. Can we go on to the next slide, please? Okay, now that was my latest learning in terms of mutations. So we do have those genes that we see them like beads on a chain, and some of those genes are cut off, therefore it will result in a truncated protein, or it may be just that a change in one amino acid. And is that significant, the change in that amino acid? I mean, one may say, well, when you had hundreds of them and everything is called in a certain particular shape, yeah, it's just one amino acid that may be lost or not have a significant impact. But also we do know, and we learned that it's important about that amino acid not to be changed or not to be the wrong one in the particular active place, active site of the protein. So there are some missense variations that may be neutral, and there are some missense variations that would be damaging. And that is the bit that we learn from case series. So it's very difficult to have population studies on checking everyone unless we test the genome of everyone, which is very costly, very timely, and I'm not sure that one generation will end up learning from it. So it's very important when we have a family history, if we haven't proven the BRCA1, BRCA2, our colleagues from genetics to be open-minded to help us to see, is there anything else like a small missense variation? And the internet is full of short case presentations with 1-2 patients developing breast cancer, and both of them in the same family having that particular missense variation. So that's how we learn from practice into science, rather than the clinical finding, learning from the science. Science learns from the practice, or the other way around, rather than the other way around. Okay, now, okay, can you go to the next one, please? Now, all right, so when, so genetics, our colleagues from clinical genetics are not working and living in a lab just testing samples. They end up learning and working with us in the MDT. So it's important not to work in isolation as specialty, and not to work in isolation as clinician. And yeah, the experimental evidence that we kept on saying it's more than essential nowadays, because again, it's quite clear truncated protein will have an impact, but what about the little changes, nuance? Will those be of an impact, clinical impact or not? So if we go to the next one. Now, you see, it's quite anticlimactic, or it was a bit anticlimactic, discussing with my colleagues oncologists that our interest and curiosity as clinicians is teased with talking about one amino acid and one protein and one active site of that particular molecule. And then we end up going back to the family history, BRCA1, BRCA2, yes or no. So I wouldn't say that there is a gap in between what we learn and what we practice. I would say that what you practice should be a bit a little bit more refined. And at the moment, those are just a few sites or apps that may help us developing our practice. To come back to the screening that was possibly, was the initial question. MRI mammogram in a high-risk patient, 30 to 40 onwards, we do yearly mammograms. Recommendations may be changed, and recommendation do varies across Europe, and that is pretty much tailored to resources. I think no clinician wants to find out that he overscanned the population and found, I know, multiple patients with a high risk and is unable to deliver an efficient service on risk reducing. I'll just take you with a mind to the screening. If we say that for screening for bowel cancer, for example, at some point the threshold for positive occult blood test in the stools was a bit lower. So a lot of patients had positive tests of the stools, but there are no capacity to do the colonoscopy or the sigmoidoscopy for those patients. So it was a bias in between, yes, let's test everyone, but there is no capacity in testing those patients. And that had an adverse impact on those patients who actually didn't have a condition, would have had negative colonoscopies, but lived for a number of months to years in the stress. Oh, I may have a cancer because my stool sample showed positive. So what if I have a cancer and I'm sitting on a cancer? So you have to be really, really mindful of, do we find this information for academic purpose, or do we find this information for changing our service delivery in general to the population, or it will change the practice to this particular patient? Thank you.
Thank you, Dr. Alexandra, for your talk. We have a question in the chat box for you. So if there are two possibly relatives with breast cancer who are diagnosed in their 30s, one in 30s and another one in 40s. So should we start the screening in a 20-year-old lady? What is your opinion? You are muted, please. Unmute yourself, please. Still you are not audible, Dr. Alexandra. Okay.
Okay, sorry.
Yeah.
Buttoning up. Okay, so we say that the screening, as a rule of thumb, we say that the screening should be 5 years before the age of the youngest relative diagnosed with the cancer. But if we have a patient with a breast cancer in the 30s or 40s, it will have that person, that index patient, will have an indication for a genetic assessment. So if on that patient we have a proven genetic mutation that we don't have to screen everyone from 20, we would test those relatives who are interested for that particular mutation. And if they don't have the genetic mutation, then they don't need any screening. If they do have the mutation, then 30 onward will still be screened. It's rather unusual. We do have patients who are 19-year-old or 20, early 20s, but we do not have a routine assessment of those genetically unless they have radiosensitive mutations. So probably 2025 would be for P53 or TP53 mutations, but otherwise not routinely. The BRCA would start from 30 onwards.
Okay. So now, yes, ma'am, would you like
Dr. Prakshi, we are actually running out of time.
Yeah.
Although we would have loved to listen to Dr. Alexandra, for some more time, but we have already overshot 20 more minutes.
Yes.
So I think we'll need to wind up.
Yes. So on the behalf of organizing team, I would like to extend my thanks towards all the eminent faculty members, to all the speakers, our panelists. And it was our 25th webinar and we touched around 200 participants, even more than that. So a big thanks to the audience also. And last but not the least, MICE Ideas, who are responsible for the smooth functioning of this webinar series. So we will be coming soon with our next webinar. See you all soon. Good night and thank you again.
Thanks.
Thank you.
Thank you, Dr. Sinu. Thank you. Thank you, everybody.